Good morning, one and all. I am Dr. Nagalakshmi, first year postgraduate. My topic of presentation is Nephrotic Syndrome. My moderator is Dr. V.S. Nephrotic syndrome is a clinical syndrome defined by massive proteinuria, which is responsible for hypoalbuminemia, which results in hyperlipidemia, edema, and various other complications. It is caused by increased permeability through the damaged basement membrane in the renal glomerulus, especially infectious or thromboembolic. It results from an abnormality of glomerular permeability that may be primarily due to an intrinsic renal disease in the kidneys or secondary due to congenital infections or diabetes or systemic lupus erythematosus, neoplasia, or certain drugs usage. Nephrotic range proteinuria is defined as a urinary loss of 3 grams or more of proteins per 24 hours or a single spot urine sample showing the presence of 2 grams of protein, UPCR ratio of more than 2, and this proteinuria can also result from other systemic diseases such as amyloidosis.
Now wait here.
Okay.
A very salient thing is nephrotic syndrome is a syndrome. Syndrome means what?
So, a group of symptoms.
Hello?
Sir.
It is not one disease, it is a syndrome. A syndrome means a constellation of symptoms, right?
Yes.
One is massive proteinuria. Second one is resultant hyperalbuminemia. Third one is hyperlipidemia. Fourth one is localized or generalized edema because of hypoalbuminemia and with various complications. So you must know all these four things should fall when you are asked to say what is nephrotic syndrome. High-grade proteinuria or massive proteinuria, consequent hypoalbuminemia, associated hyperlipidemia, edema, and then various complications. The main pathology is damage to the basement membrane of the renal glomerulus. Okay?
Okay.
And second important thing is the permeability of the glomerulus has increased. Primarily, it could be due to an intrinsic renal disease, or it could be secondary due to congenital, infections. They have not put a comma in this. There are no congenital infections. Congenital causes infection, diabetes, systemic lupus erythematosus, neoplasia, and drugs. So primary disease of the kidney, and secondarily most common is diabetes and SLE. Okay. And then what is nephrotic range of proteinuria? Minimum of 3 grams of protein or more in 24 hours. Or who is going to measure 24 hours? Easy to measure a single spot urine. In that you must get 2 grams per gram of urinary creatinine.
Yes.
Okay. So that means at least 2 by 2. So or more. This proteinuria can also result from other diseases also, particularly pregnancy. The third trimester of pregnancy can produce nephrotic range of proteinuria, which is a feature of the preeclampsia. Right? So these are the salient points we have to hit a nail in this particular slide. Okay, let us go.
Coming to etiology, it can be due to congenital or primary causes and secondary causes. Congenital causes may be focal glomerular sclerosis, could occur because of genetic mutations in the podocyte protein such as podocin, nephrin, or the cation channel 6 protein. Primary causes are mostly membranous nephropathy, minimal change disease, and focal glomerulosclerosis. Secondary causes include systemic diseases, diabetes mellitus, and immune causes like lupus erythematosus and amyloidosis.
Okay. Now again, what is important on this slide? You focus on there is a lot of English there. What is the important thing in this that you wanted to learn from this slide?
The most common causes.
What are the most common causes?
In children, it's focal. Congenital causes include FSGS, due to genetic mutations in the proteins, sir.
It's very rare, no. Just because they are given in the article, how many congenital nephrotic syndromes we see? That is not at all a cause. There could be a sort of congenital nephrotic syndrome, in which case you will get the following things. One, there will be a mutation of the podocyte protein, such as the podosin or nephrin or cation 6 protein. But that is not the common cause. What is the common cause?
Animal change disease. Membranous nephropathy.
There one-third rule. What is that one-third rule? In adults, one-third belong to the minimal change disease. One-third belong to the membranous nephropathy. One-third belong to focal glomerular sclerosis progressing onto global glomerular sclerosis. Understand? In the adults. Whereas in children, 85% is minimal change disease. 10% is membranous disease. 5% only is the focal. So now you have to put a table here and show me that children and adults. Children, commonest one, minimal change disease. Next common one, 10%, membranous disease, membranous glomerulonephropathy. Focal glomerular sclerosis is only 5%. Whereas in adults, one-third. That is 30% due to minimal change, another 40% due to membranous, and another 30% due to focal glomerular sclerosis, progressing on to global glomerular sclerosis. This is the first important statement. Then there could be secondary causes of nephrotic syndrome, which are systemic diseases, commonest being diabetes mellitus, second one being lupus nephritis, and third one is amyloidosis, and some drugs also. Rarely, I have to say rarely, nephrotic syndrome may be a congenital nephrotic syndrome, in which case we see genetic mutations of the podocyte protein such as protosin, nephrin, or cation 6 protein. Infections also can play a part in the secondary type of nephrotic syndrome. Now, did you understand that?
Yes, sir.
So the presentation in adults is quite different from the presentation in children. And prognosis wise also, minimal change disease, excellent prognosis and very good remission. Okay. And then membranous glomerulopathy, reasonably good prognosis. Majority of them recover. Only few need dialysis and they go into end-stage renal disease. Whereas focal glomerular sclerosis, it can occur. It can cause devastating renal impairment. The patient may end up in dialysis and end-stage renal disease and may require renal transplantation. Now, after the class is over, you write a sort of a table wherein you put 3 columns: focal glomerular disease. First one is minimal change disease. Second one is membranous nephropathy. Third one is focal glomerular sclerosis. And write the salient features of each: age, then prognosis, proportion of patients, and then the requirement for end-stage renal disease, and then transplant and all that. Okay. That way you have to understand, not like big English sentences and all. If you jumble up all the things in the sentences, nothing comes out into your brain, isn't it? Now go ahead. And secondary causes. The fourth line is the secondary causes. Okay. First line is minimal change. Second line is membranous. Third column is the focal glomerular sclerosis. Fourth one is secondary. Under each box, you fill up the relevant details and show me. Okay. Now come.
Secondary causes include, most common is diabetes mellitus, and second is autoimmune causes, lupus erythematosus, antibody vasculitis, and Burgess disease, and anti-neutrophilic cytoplasmic neutrophils, and Goodpasture's syndrome, extramembranous or membranoproliferative glomerulonephritis, and thrombotic microangiopathy, allo antibodies from enzyme replacement therapy. And infections include human immunodeficiency virus, hepatitis.
In the immune itself, we have forgotten. You have read everything about cytoplasmic neutrophils, ANCA and Goodpasture, but you have forgotten one important thing called the non-steroidal anti-inflammatory drugs and gold salts, which are treatments used in in rheumatoid arthritis. Okay. Under this paragraph, what you need to learn only two things. Lupus erythematosus, you must know. Good pastures, you must remember. ANCA, you must remember. Non-steroidal anti-inflammatory drugs and gold salts. Gold salts are nowadays not being used. So, non-steroidal and all others are various types of immune diseases. How does it differ from the other one? There will be immune complex deposition on the basement membrane. How do I see that in the clinically? C4 and C3 complements will be reduced. Complement reduction in the peripheral blood can be seen. Okay. So secondary causes, first is diabetes, second one is immune. Important ones are SLE, ANCA, good posture, NSAIDs, and gold salt. NSAIDs due toxicity due to NSAIDs. Okay. And then you go for infections and other things and drugs. Okay. Go ahead.
In infections, it is due to HIV or hepatitis B or C virus or cytomegalovirus and parvovirus, preeclampsia and toxoplasmosis and amyloidosis and paraproteinemias.
Yeah, here the jumbled up everything. How can preeclampsia be infection? So the other causes include HIV, hepatitis B, hepatitis C virus, CMV virus, preeclampsia, parasitic diseases like toxoplasmosis, amyloidosis, and paraproteinemia. Infections and other causes. You have to put here infections and other causes. Okay. Okay. Drugs. What are the drugs that cause?
Heroin and interferon alpha, lithium and NSAIDs and pamidronate.
Non-steroidal anti-inflammatory drugs are direct toxicity due to them. What happens is, majority of the time in adults, left and right for some pain or other, they keep on taking the non-steroidal anti-inflammatory drugs. And sometimes these end up in a patient going into the nephrotic syndrome. Okay. Now, summary of the primary causes. Primary causes are three types. Okay. One, minimal change disease. Number two, membranous glomerulonephropathy. Number three, focal glomerular sclerosis. Focal glomerular sclerosis with NS, nephrotic syndrome. So these are the three things. And the secondary causes, commonest diabetes mellitus, at 10 years or more of diabetes mellitus, and then immune causes like SLE, ANCA, good posture, and non-steroidal drugs acting as haptens and producing a immune complex deposition in the glomerular basement membrane. Infections and other causes, HIV, hepatotropic viruses like B and C, CMV can also produce. Most importantly, nephrotic range of proteinuria can be seen in patients with pregnancy, third trimester, preeclampsia. Toxoplasmosis, amyloidosis, and paraproteinemias are also other causes. As far as drugs are concerned, heroin and other addictive drugs, not only heroin, other addictive drugs like marijuana and other things also, interferon alpha, lithium, NSAIDs, and pamidronate. What is pamidronate? What is pamidronate?
Pamidronate is
when you have osteoporosis, you give bisphosphonates, isn't it? This is one of the bisphosphonates that you use. Alendronate, pamidronate. These dronate. If it comes, it is a bisphosphonate.
bisphosphonates.
Bis means two. Bisphosphonates. Bisphosphonates are treatment for severe osteoporosis. Okay. So now you have presented, but the material is embedded in the English. You have just taken the English then and copied here. That is what I don't want you to do. When you read an article, you must find out what are the salient things and then put it in your own English and classify them properly. They have not done that. Okay. What is the very basic pathophysiology?
The glomerular capillaries are lined by fenestrated endothelium, which sits on the glomerular basement membrane, covered by glomerular epithelium or podocytes, which envelop the capillaries with the capillaries cellular extensions called foot processes. These processes interdigitate with the special cell-to-cell junctions called the slit diaphragm, which together forms the glomerular filter. Normally, the larger proteins, which are greater than 69 kD in size, are excluded from filtration. The destruction of podocytes above a critical mass leads to irreversible glomerular damage, and filtration of plasma, water, and solutes occurs extracellularly and through the filtration slits and endothelial fenestrae.
All that, if you have put a diagram here in this side of the slide, I expect you to put a diagram. So how do I put a diagram? We have to write a diagram there. Either you can take it from the internet or put it. So roughly I'm saying if this is a glomerular, and these are lined by endothelial cells. Glomerular epithelium. And this thick one is the basement membrane. This is the BM. Okay. And these cells have got what are called the podocytes. This cell will be like that. And there will be another podocyte. Foot processes are there. This is the foot. And they interdigitate and produce what are called the slits there. Okay. So these allow the slit diaphragm. This is called the above is the basement membrane. Okay. Above is the basement membrane. And there are openings here for water to filter, sodium to get filtered, and all the electrolytes. But any protein more than 6 kilodalton is withheld. It is not allowed to pass through. Okay. And these are lined by the capillaries and podocytes. This is the luminal side of the tubular slide. This is the glomerular side. Okay. Now, what happens in nephrotic syndrome is this basement membrane is damaged and the podocytes are separated. Instead of being close to one another, there will be a gap in the podocytes and the leakage of protein through that. Large molecules are allowed to leak down. Okay. This diagram would have been very helpful for you to understand what exactly is going on.
Yes.
It's not there in the article, but you can find out where exactly the basement membrane podocytes diagram. Instead of imagining something, it is better to physically see a diagram of the glomerular basement membrane and the podocyte structure as can be seen in the diagram. Okay. So roughly this is what it is. Okay.
The glomerular changes that may lead to proteinuria or damage to glomerular basement membrane and the endothelial surface or the podocytes. Albumin is the main constituent in proteinuria, which accounts for 85%, and albumin carries a net negative charge. The loss of glomerular membrane negative charge plays an important role in causing albuminuria. A generalized defect in glomerular permeability is associated with non-selective proteinuria, causing a glomerular leakage of various plasma proteins.
What did you understand by this slide?
Due to damage in the glomerular, increased glomerular permeability and damage of glomerular basement membrane, which leads to loss of protein, which leads to hypoalbuminemia, sir.
That is true. That is what they're explaining the mechanism. This is the glomerular basement membrane. Okay. Below are the endothelial side. You have got this so-called podocyte. Okay. Foot processes. So normally these are negatively charged. Okay. And albumin is also negatively charged. So they repel each other and albumin is not allowed to enter. Okay. Now what is happening is here, because of the damage, the negative charges are lost and they become neutral. Then albumin has got no repulsive force there and albumin leaks. Okay. All this is because damage to the glomerular basement membrane and onto the epithelial side endothelial side of the food processor. So the endothelial surface of the food processors and damage to the glomerular basement membrane, consequent proteinuria, 85% of the protein is albumin. It is a net negative charge is more because loss of glomerular basement membrane negative charge plays an important role. This is normally negatively charged. That negativity is gone. So normally it is net negative charge is neutralized. And that is not neutralized now. Albumin has got a free access into the glomerular filtrate. A generalized glomerular permeability also can result in proteinuria. It can be due to the negative charge, or in general there could be a membrane may be very defective, very leaky membrane, and the cells are piled apart, and that can also produce proteinuria. One mechanism is net negative charges increased, and second thing is to a generalized leak. Two mechanisms are explained. Why don't you try to understand and then put it in beautiful points like things? How do I do it? Whatever is there only I have now explained to you, isn't it? Okay, go ahead. Okay.
Okay, sir. Pathogenesis of edema, there are two hypotheses, underfill and overfill hypothesis.
Explain them. If you had studied, explain what is underfill hypothesis and what is overfill hypothesis. Instead of reading all the English, put it in your own words and tell.
Okay, sir. In
underfill, what happens, and overfill, what happens?
In underfill, there is an increased glomerular permeability, which leads to proteinuria and then leads to hypoalbuminemia. So therefore, there is decrease in plasma colloidal osmotic pressure, sir. So there will be an increased transcapillary filtration of water. So therefore, it results in edema, sir.
Okay.
That is about.
See, what you have to understand is there is some oncotic pressure in the capillary, and this oncotic pressure is decreased because of albumin leak. Once the albumin leaks, there is hypoalbuminemia. Hypoalbuminemia is circulating all over the body, and it goes to the tissues. The capillaries are not having the pressure to the oncotic pressure to withhold water inside, because the hypoalbuminemia itself, or protein itself, is the oncotic pressure which keeps the fluid within the capillary. So because of hypoalbuminemia, the capillaries are not able to hold water, and water goes into the interstitium and causes edema. This is what is called underfill hypothesis. Normally what happens, whatever fluid has come into the interstitium will come back and join at the venous end of the capillary, because the plasma proteins will be calling, come on, you fellows, you have gone out. And there is a sort of invitation by the colloidal oncotic pressure to pull back the fluid into the system. Here, the protein itself has gone into the interstitium. Then what happens? The oncotic pressure of the interstitium will be increasing. So the net oncotic pressure at the venous end of the capillary is lower, and there is no one who is calling. Instead, there are many fellows who are keeping the fluid there in the interstitium. This is what is called the underfill hypothesis. Now you tell in your words, in these words.
There is increased glomerular permeability, sir. Okay, so therefore, there is more protein filtration through the membrane, so leads to proteinuria, and which results in overall hypoalbuminemia in the body. So there is less protein. So generally protein accounts for colloid oncotic pressure. So there is decreased plasma colloid oncotic pressure, and there will be increased filtration of water from the vascular compartment to the interstitium. So therefore, there would be peripheral edema and also.
Correct. So if this is the capillary, this is the arterial end, this is the venous end, and there are proteins here, and these proteins hold the water with that. Whatever water is filtered now, that water has to come back, because these proteins will ask it to request them to come back. Okay, you fellows, you have gone in search of the tissues to supply nutrition. Your job is up. Come now and join us, because there is a pull here. But here what is happening, these fellows themselves are less. So there is nobody who is pulling here at the venous end. So much so the water itself is stagnating in the interstitium. Okay?
Yes, sir.
This is the underfill hypothesis. Next, overfill hypothesis.
In overfill hypothesis, there is an intrinsic defect in renal tubules which causes decline in the sodium excretion. Generally, sodium retention starts even before serum albumin tends to fall, and there is an exaggerated peripheral capillary permeability and to albumin. And then it is reported in radioisotopic technique studies in about 60% patients with nephrotic syndrome, sir. And there is an increase in the interstitial oncotic pressures.
Okay. What did you understand? Now again come back.
Mm.
Now you tell me in your own words. You have written the English there. I understand. But then now you have to give me the explanation. How did you understand that?
Due to defect at the renal tubule, sodium excretion is decreased, sir. So due to more sodium in the body, and then water retention also happens, sir. This is all because of increase in the interstitial oncotic pressure.
Okay. So what is happening? There is leak of the sodium there. The filtration of sodium is hampered there. That the intrinsic defect in the reabsorption of in the renal tubules, which leads to a decline in the sodium excretion. That means net sodium balance in the body is positive. That means there is excess sodium in the body. Sodium always retains water. Okay? The intraluminal protein directly causes the renal epithelial sodium reabsorption, and sodium retention occurs. There are two things. One, there is a protein in the lumen of the tubule. Normally, there is no protein in the lumen of the tubule. This protein helps the sodium to get reabsorbed. So there is an increase in reabsorption. And that means the decreased excretion of the sodium. That means there is sodium retention. Sodium retention causes water retention and causes anemia. This is evidenced by 2 or 3 things. One, even before the serum albumin were to be the cause of edema, even before the serum albumin levels start to fall, we are seeing edema. That means there must be some other mechanism like the retained sodium. And also intravascular volume is usually normal or even raised in many patients with nephrotic syndrome because of sodium retention. Okay. And this exaggerated peripheral capillary permeability to albumin, as reported in the radioisotopic technique studies of 60 patients with nephrotic syndrome. So there is what is called a peripheral capillary permeability to albumin is increased. With the result, what is happening? Now in the vascular compartment is there is more sodium molecules here. These sodium molecules, because of the decreased excretion, sodium goes into the interstitium, that retains water also, there is edema. And also there is evidence that there is increased filtration of protein also here into this. This protein again retains water, along with that sodium also retains water. So there are 2 mechanisms that they are postulating in the overfill hypothesis. One is net sodium excretion is decreased due to the protein leak into the tubule. The sodium is reabsorbed more, net excretion is decreased, net circulating sodium is more, the circulating sodium appears in the interstitium, that retains water. The second thing is that an increase in the capillary permeability at the venular end or in the capillaries themselves, and that results in leak of the protein into the interstitium, and that could cause water retention along with that, and that is the cause of edema. This is evidenced by the fact, well before the sodium levels, albumin levels fall, we are able to see edema in many patients. Also, even when the intravascular volume is normal or raised, then also in nephrotic syndrome. Otherwise, what would have happened if it were to be the first hypothesis? The intravascular volume would have come down because the proteins are less, they are not able to retain water, water is stagnating in the interstitium. That means there is what is called a decrease in the plasma volume or circulating blood volume. That is not there. Even when there is normal volume or raised volume also, we are able to see edema. Means what? Their sodium must be playing an important part. Why do I need to know this? What is the necessity to know this one? What is the necessity to know this one?
To know the underlying mechanism, what happened?
Yeah, supposing I know the underlying mechanism, what big thing will happen for me? Treatment, ma.
Yes, sir.
Supposing the sodium leak is the hypothesis is agreed, return of sodium is agreed, then what I have to do? Then I have to restrict the sodium, isn't it?
Yes, sir, diet.
Dietary restriction. In the first one, because there is a leak of the albumin, I have to do what is called, increase the protein intake. So supplemental protein and decrease in the sodium are important for the treatment modalities in the general measures of nephrotic syndrome. In order to understand that, these mechanisms are postulated here and you are made to understand that. Now you write these two things. The pathogenic mechanisms of edema, you write it up. The writing is the best way of remembering. Put a diagram just as what I have put, and then refine my diagram and then put it. Or take the diagram from the venous end of capillary, arterial end of capillary, the diagram from a book, like the glomerular basal membrane and podocytes, that also take from a book, and you draw your own diagram and then explain. I have put whatever is in my mind, I have put a diagram. I didn't look at any diagram today morning. But you can as well do that, isn't it? Okay. Now, histopathology.
Okay. In minimal change disease, it is the most common thing. It's seen in 77 to 85%. Usually, it is idiopathic. On light microscopy, there is effacement of food processes, sir. Light microscopy shows no changes, whereas in electron microscopy, we can see effacement of food processes.
That is important. Meaning the very fact that it's worded as minimal change disease means you don't see any changes in the light microscopy. Only when you look at the electron microscopy, you can see the food processes damaged and the slits are increased. In the openings, there are increased. And if you do an immunofluorescence staining, you can see some immune complex deposition if it is membranous type. If it is minimal change disease, you don't see any immune complex. That is why the immune complexes are negative in minimal change disease. Minimal change disease histologically is qualified by the following statements. One, this is the commonest thing in children, about 85%. Second thing, there are no secondary causes for minimal change. It is idiopathic. Third, light microscopy does not show any change. That is why it is called minimal change. Electron microscopy shows food processes damage and change. And fourth one, there is no immune complex deposition. This is a minimal change. Okay. Then you must describe what is called the membranous. And finally, you must describe focal segmental glomerulosclerosis. In the journal, they have given in this order, but the general order of description is minimal change, membranous, focal glomerulosclerosis, because that is the rarest of the three, and that is the most fatal one. Okay. Now, tell about segmental FSG.
In FSGS, it accounts for 10 to 15% of cases. In light microscopy, we can see scarring or sclerosis, which can later progress to global glomerular sclerosis and tubular atrophy, sir.
Yeah.
And there is negative immunofluorescence.
Yes, that is another important. Just like the minimal change disease, it is not an immune-mediated thing. So there is an immunofluorescence is negative, and there is a focal glomerular sclerosis to start with, and it occurs around 10 to 15% of patients fall into this category. And the light microscopy samples show because of the glomerular sclerosis, there will be focal scarring will be there and sclerosis will be there, and portions of the selected glomeruli, they will progress on to global glomerular sclerosis, and this will be accompanied by the tubular atrophy. Okay, give the renal biopsy specimen to them. See, normal glomeruli interspersed with some glomeruli which are scarred. So that's why it is called FSGS, focal glomerular sclerosis. Immunofluorescence is negative. It is a rarer of the three causes, most fatal of the three causes of pathogenesis. Okay?
Okay.
No membranoproliferation. I want this to be as a second entity and then the focal glomerular sclerosis. Doesn't matter. You go and read now.
Membranoproliferative glomerulonephritis presents as a nephrotic syndrome. It involves immune complex deposition, and immunofluorescence is positive, showing a granular pattern. On light microscopy, we can see thickened basement membrane.
There are changes, sir. One, it is one of the very common things in adults, whereas the adults it is minimal changes, the commonest thing. Second thing is it presents itself as nephrotic syndrome directly. That means edema, proteinuria, and all that are very full blown in this. There is immune injury, immune complex deposition is there. It could be a secondary or it could be primary. Primary means there is a thickening of the basement membrane in the light microscopy. And when you see immunofluorescence staining, you see the deposition of immune complexes that gives a granular pattern to the glomerular. Okay. Secondary means it could be a nephritis or diabetic nephropathy, or it could be toxins or ANCA or good postures or any one of those conditions. Drugs for acting as haptens and producing immune injury, NSAIDs and things like that. Okay.
In membranous glomerulonephritis, it accounts for 2 to 4% of the cases in children, but the most common type in adults. On light microscopy, we can see thickened basement membrane, and there is a characteristic spike and dome appearance in electron microscopy, sir, and with subepithelial immune complex deposition.
Okay. What happens is, this is the basement membrane of the glomerular, and these are your cells there, and the immune complexes are deposited along the basement membrane. And these immune complexes are deposited along the basement membrane. These will be like spikes. And like a dome connecting them. This is called the spike and dome appearance that you see in case of membranous glomerulonephritis. It's a very common cause in adults and very minimal, around 2 to 4% of children only have membranous glomerulonephritis. In thickened basement membrane and granular pattern is the hallmark. Okay. Clinical features.
Children usually there's a facial puffiness, which followed by edema of the entire body. In adults, usually there is a dependent edema. Frothy urine may be seen, and there's a tiredness and lack of appetite. And in a few cases, there is a thrombotic events such as deep vein thrombosis of calf veins or pulmonary embolic event, which could be a first indication of nephrotic syndrome.
Yeah, that's a very rare presentation. Now, I have a child who is a relative of mine. He is 5 years old. He was the first presentation of the last 3 months. He is not eating well and lack of appetite, and he is listless and sleeping wherever he is there. He is found to lie down and not eating well. Then what happened was, when I went to their house, I saw him like this, and I said, you just examine the urine. And urine is 3+ protein. And the disease is minimal change disease. Now the fellow is under steroids, has recovered, his appetite has improved, he is now active and doing everything. So you must have suspicion. A child not taking feed, feels tired, something is wrong. Common thing is hepatic disease and liver disease and renal disease. I asked them to urine thing to be done, and creatinine and urea, and also a liver function test. Liver function tests are normal. Urine showed 3+ proteinuria. Immediately we did protein creatinine ratio. We diagnosed minimal change disease. Since it does not have any other secondary causes, nor he has got other features of the body and in the body about other causes. 85% of the cases are minimal change disease. So this fellow is minimal change disease. Now, there are two variants of nephrotic syndrome. One is called the steroid responsive, the other is called the steroid non-responsive. And majority of the people with minimal change disease, they are steroid responders. These responders are also classified as early responders, okay, moderate responders, and then late responders. Early means within 2 weeks after steroid therapy, they will hear up to 6 weeks. And these take more than 6 weeks for them to give a absence of proteinuria in the urine. So how do we assess? Do protein creatinine ratio on a 24-hour urine, and if it is not feasible, you do on a spot urine protein creatinine ratio. And if that is more than 2 grams per gram of creatinine, then it is an increased protein creatinine ratio. Okay, and now deep venous thrombosis presenting with DVT is, not a common presentation at all. You don't see that very much in nephrotic syndrome, although it can occur. Not that it doesn't occur, it's not very common. So you have to learn early responders, moderate responders, late responders to steroids, non-responders. Another category is NR. If it's non-responder, you have to go for other drugs to treat the nephrotic syndrome. Okay. What the point here is, we picked up the fellow because of lack of appetite and tiredness. They may not present with overt facial swelling all the time. So it may be there, but it may not also be there. Dependent edema in case of adults, but particularly pedal edema. Children, it is facial edema. So you understand the importance of this slide?
Yes, sir.
Go. What are the investigations you do?
First, we'll go for urine examination. So generally, proteinuria would be 3 plus or 4 plus on dipstick method or by semi-quantitative testing by sulfosalicylic acid. A 3 plus reading represents 300 milligram per deciliter of urine protein, which correlates to daily loss of 3 grams or more protein, and which is nephrotic range.
Okay. Now, anything between less than 3, normal, 3 to 300, microalbuminuria, more than 300, macroalbuminuria, more than 3000 milligrams or 3 grams is nephrotic proteinuria. These are in milligrams. Less than 3 milligrams, normal. 3 to 300 is the MAU, microalbuminuria. More than 300 is overt proteinuria, that is macroalbuminuria. More than 3000 is nephrotic proteinuria. This classification you must know. Less than 3 milligrams, 3 to 300, more than 300, more than 3000. More than 3000 is 3 grams of protein, nephrotic range. Okay. So another thing is 24 hours is the best one, but you may not always be able to do 24-hour collection, particularly in a child, and you better to do a spot protein also in such case. Okay.
Yes, sir. Urine analysis may also demonstrate CAS, which can be hyaline or granular, fatty, waxy, or epithelial cells. And lipiduria, there is a presence of free lipid or lipid within the tubular cells or within CAS or as free globules, which suggests a glomerular disorder.
Remember here, the CAS, if you see, are hyaline, granular, fatty, waxy, epithelial CAS, and not RBC CAS. The presence of RBC, hematuria, RBC CAS indicates acute nephritis and not nephrotic syndrome. Okay? Presence of leaking blood in the form of RBC or RBC CAS, which is a microscopic hematuria, that is a hallmark of acute nephritis and not a feature of nephrotic syndrome. Okay. But nephritis can progress onto nephrotic syndrome over a period of time. But initially, it can present with RBC cas, then protein in the range of nephrotic proteinuria, leak can occur, then the RBC cas disappear. Okay. And serum albumin is classically low because of hypoalbuminemia, because of albumin leak, there is hypoalbuminemia. Okay. What is the normal serum albumin range? 3.5 to 4.5.
0.5 to 4.5 grams.
Here it is less than 3 grams, and usually it may be 1.5 or 1 gram also. And all elements of your lipids can be elevated. Triglycerides and cholesterol most commonly, sometimes LDL, sometimes VLDL, sometimes chylomicron, sometimes HDL, but the common ones to be elevated are total cholesterol and triglyceride. This fellow, which I told you, he has got triglycerides elevated and total cholesterol elevated. Hyperlipidemia also is there in him, and there are no RBC cas, and urine showed only hyaline cas, no RBC cas. Okay, the child is now recovering. Now, what serological test you can do?
For secondary causes like diabetes mellitus, serum glucose, and HbA1c. And autoimmune causes, antinuclear antibodies, and for infectious causes, hepatitis B, C, and HIV, and serum or urine protein electrophoresis, cryoglobulins, and rheumatoid factor, and for serological tests for syphilis, RPA test, RPR, and HIV antibody test and complement levels.
One line for all this is, these tests are unnecessary. Generally, in primary nephrotic syndrome, none of these will be positive. Only in the secondary nephrotic syndrome, some of them will be positive. If I have 100 cases of nephrotic syndrome, 85% are primary renal disease. Only 15% are secondary to a known cause, like SLE, diabetes, cryoglobulinemia, all those things. So, in a routine patient, evaluating for secondary causes is futile unless you have evidence of a secondary disease. For example, somebody is a diabetic, yeah, you can evaluate for secondary causes of diabetes causing the nephritis. Somebody has got SLE, you can evaluate for SLE nephritis. Somebody has got rheumatoid arthritis, you can evaluate for rheumatoid arthritis causing nephrotic syndrome. Somebody has got HIV, you can evaluate for that. In the absence of a leading clinical feature or evidence of other diseases, presume the disease to be primary nephrotic syndrome. That is primarily affecting the kidney, either minimal change or membranous or focal glomerulosclerosis. Okay? In Western world, focal glomerulosclerosis is very rare. In African descent, focal glomerulosclerosis is the presentation. In India, it is focal glomerulosclerosis, not seen much, minimal change in membranous only. In Western world, it is membranous is more seen, minimal changes, less seen in adults. Focal glomerulosclerosis is almost extinct or rare. Whereas in African descent, one third. Something like, you have a lot of focal glomerulosclerosis and membranous and also minimal changes. Remember, whatever tests you have mentioned here are useful only in the presence of an evidence of secondary disease. That is where the role of testing is rather controversial. Okay? Yield may be very low. Ultrasonography.
Ultrasound is done for assessing renal echogenicity, and individuals with a single kidney may be prone to develop focal glomerulosclerosis. Having only one kidney is a relative contraindication for renal biopsy.
Why? Suppose the fellow has got only one kidney, and if you do a renal biopsy and introduce infection and damage that kidney also, he will die. So, unless there is a strict indication, renal biopsy in a single kidney is contraindicated. In fact, renal biopsy is not the evaluation tool for glomerular, for nephrotic. So required only in very rare cases where it is non-steroid responsive, where you are considering focal glomerular sclerosis, then only you require a renal biopsy. Otherwise, renal biopsy is contraindicated. Renal biopsy is not required to routinely diagnose. So what you have to do? Urine analysis, urine 24-hour protein, ultrasonography. These are the only three tests you have got. So, and blood test for the asthma and cholesterol. Urine analysis, urine proteinuria, demonstrate the nephrotic proteinuria, do the protein creatinine ratio, do the albumin, and look at the cholesterol and triglyceride, and do the what is called the ultrasonography. You don't have to do the serological test nor the renal biopsy. Ultrasonography also demonstrates increased renal ecogensity. It is consistent with intrarenal fibrosis. What is increased in renal ecogensity? This is the kidney of the ultrasound. And this is the medulla. This is, hyperechoic, and this is usually hypoechoic. Now, here also it becomes hyperechoic, like the medulla, and the corticomedullary differentiation becomes rather poor. This is what we called corticomedullary differentiation poor. We will write the ultrasound. Okay, because of the increased ecogensity of the renal parenchyma, and it will become as it looks as though it is medulla-like thing, renal medulla. Okay, now.
Renal biopsy and phospholipase A receptor tests are rarely done. In renal biopsy, it is indicated for the following conditions like congenital nephrotic syndrome, and if the age of onset is more than 8 years, and steroid resistant cases, and if there are frequent relapses or steroid dependency, or any nephritis manifestations, sir.
No, what you have to do? Congenital nephrotic syndrome. Certainly, yes, because you take the biopsy sample and submit it for genetic testing. There could be, protein, different protein mutations can be there that we have known. Or if the child is more than 8 years at the onset and presenting with nephrotic syndrome, it is not minimal change disease, because by then the membranous nephritis and focal glomerular sclerosis might be there. And steroid resistant patients, you can do renal biopsy, or fellow who is having frequent relapses, or steroid dependent. Without steroid, there is no remission. The moment you stop steroid, again the relapse comes. That's called steroid deficiency. Or he has got nephritic manifestations like hematuria, microscopic or macroscopic hematuria. Then you would like to pin down the cause by doing a renal biopsy. Kidney biopsies frequently reveal glomerular disease to be the cause of nephrotic proteinuria and not tubular disease. Generally, proteinuria means people think it is tubular disease, but it is not tubular disease, but it is more a nephrotic range of proteinuria, as evidenced by the glomerular disease, if at all you do a renal biopsy. So, number one about renal biopsy, generally not indicated. Number one. Number two, it can be done in the following conditions. 1, congenital nephrotic syndrome. 2, late onset in childhood. 3, a fellow who is steroid resistant. 4, who is steroid dependent and relapses are occurring when the steroids are withdrawn. 5, the patient is presenting with a nephritic feature. As clear as that. Should have written like that. 1, 2, 3, 4. Phospholipase A receptor, PLAR. What is PLAR?
It's phospholipase A receptor, sir. It is present in the membrane. In membranous nephropathy, we have autoantibodies against this receptor, sir.
So, if somebody has got PLAR positive, we are idiopathic membranous nephropathy, not secondary membranous nephropathy. Secondary membranous is due to diabetes or SLE. Primary membranous nephropathy is, the mid type of disease. Minimal change disease, membranous proliferative nephropathy, and then the focal glomerular sclerosis. In the membranous nephropathy, PLAR may be positive. It is an antigen in the which is expressed on the surface of the podocyte, which we are now getting as the immunological autoantibodies to PLAR. Okay, there is a strong correlation between levels of this antibody and the clinical disease activity. Therefore, it is useful as a prognostic tool and in the treatment also. The more the PLAR, the worse is the prognosis. The lesser the PLAR, the better is patient is responding to the treatment. Absence of these antibodies could indicate secondary nephropathy, such as that linked to cancer, diabetes, or membranous nephropathy only. PLAR positive, primary. PLAR negative, secondary causes. Right?
Okay.
See, this is a difference between the way in which you read the article and the same article when we read. So the information is there on your slide because you have taken it from the text there. But the understanding is important. Okay. How do I treat and manage?
Before starting steroids, we have to assess detailing the patient's height, weight, and BP should be monitored, and regular weight monitoring is required to notice whether the edema is decreasing or not. The treatment varies between adult and pediatric populations. In children, we usually use corticosteroids for idiopathic nephrotic syndrome, and alternative immunosuppressant agents is used for frequent relapses or steroid-dependent nephrotic syndrome, sir. Immunosuppressants include cyclophosphamide, mycophenolate mofetil, and calcineurin inhibitors or levamisole. In steroid-resistant nephrotic syndrome, the first line of choice is calcineurin inhibitors, such as tacrolimus or cyclosporin, and then agents such as MMF or prolonged or intravenous pulse corticosteroids can be used, sir. And then anti-B cell antibody rituximab can be used.
Now we are left with the management includes like this. First of all, I will say assess the weight regularly and see the proteinuria, monitor proteinuria properly. So weight for height and blood pressure in adults. In children, blood pressure is not an important thing. Height and weight are important to monitor the weight gain or weight loss. Regular weight record is essential. Restrict protein to 1 gram per kilogram body weight. Okay. Salt 3 grams per day in adult. Okay, 3 grams of sodium chloride per day in adult. This is the prescription. Then, when you are treating a child, you can be doubly sure it is minimal change disease and start on steroid without any secondary evidence required. Okay. Now, when you start, but in adults, it could be diabetes, it could be nephrotic syndrome. If it is diabetes, steroids are not indicated. Nephrotic syndrome, due to SLE, steroids will be indicated depending on the cause. In children, we have started on the corticosteroid. How much we give depends upon the body weight of the patient. Okay, around 30 to 50 milligrams of prednisolone per day, you have to give in 2 or 3 divided doses. Now, if they respond within 2 weeks, 6 weeks, I wait. After that, at the end of 6 weeks, no response, they are called the non-responders. 2 to less than 2 weeks, early responders. 2 to 6 weeks, moderate responders are, and little later they respond, late responders, non-responders, classify the patient. Suppose he is non-responder, the best drug that I have in my choice is tacrolimus or cyclosporin. Okay, this is the calcineurin inhibitor can be used. Cyclophosphamide can be used or MMF can be used, calcineurin inhibitors can be used. Steroid not responsive, first choice is tacrolimus or calcineurin inhibitor. And if there is no response, then of course you can use MMF and or pulsed corticosteroids, IV pulsed corticosteroids. Now, here there is a problem in giving the steroids. If you give steroids orally, what will happen in people with nephrotic syndrome? There is edema of the gastrointestinal mucous membrane also. Okay, just like the edema of the peripheral tissues, GI mucosa also is edemated, and the absorption of the steroid from the gut is reduced. So much so initially you would prefer to give by needle And then once the patient is responding and the GI edema comes down, then you can give oral. That's an important point which is mentioned in the article somewhere, but it could have been brought out here. Supposing I have exhausted my MMF, cyclophosphamide, and the calcineurin inhibitor and pulse steroid therapy, I am left with rituximab anti-BCL antibody as a treatment. This can be used as an effective treatment when in order to spare the steroids. It's called the steroid sparing agents in some pediatric population, particularly who develop a lot of steroid-induced side effects. Rituximab can be a choice. Sometimes rituximab may not produce drug-free remission in children, and both calcineurin inhibitors and steroids can be used in such a case. Rituximab may have a role in children who have steroid-resistant disease.
Yes, sir.
Acute nephrotic syndrome.
In acute nephrotic syndrome, children population, they present with facial swelling and generalized edema if severe leads to respiratory distress, and then scrotal or labial edema. There is a failure to thrive, and certain complications like bacterial peritonitis, pneumonia, sepsis, and thromboembolism.
Yeah. What do we do in acute nephrotic syndrome? Diuretics have to be used.
Yes, sir. Diuretics are usually needed. Furosemide 1 mg per kg per day and spironolactone 2 mg per kg per day when fluid retention is severe enough. There is no signs of kidney failure or volume contraction. We can use this combination.
Can give up to 240 milligrams of furosemide maximum dose.
Yes, sir.
Okay.
When serum albumin is less than 1.5 grams per deciliter, satisfactory diuresis can't be achieved, sir.
Yeah, because the hypoalbuminemia is there, it retains fluid in the periphery, in the interstitium, and doesn't allow the fluid to come to the kidney to be excreted. So hypoalbuminemia is so severe that the edema is stuck it is sequestered in the interstitium and is not able to come to the kidney for excretion.
Yes.
Okay.
If it is less than 1.5 grams per deciliter, we can go for IV albumin. And to prevent further infections, penicillin can be started in children with overt edema, and abdominal paracentesis can be done, sir. For the patients who show signs of peritonitis and bacterial infection should be treated early.
3 points you all have to know. 1, no role of renal biopsy unless you are suspecting something very different. Routinely done renal biopsy. Second thing, no special investigation other than urine analysis, serum proteins, no special investigation. Number 3, okay, steroids are the first agents to be tried. If not responsive, then consider other things. No prophylactic antibiotic. There is no role for, studies have not shown, no prophylactic penicillin or antibiotic. Likewise, no prophylactic, no antithrombotic, like heparin and others. Okay, unless there is evidence of thrombosis. This is no distance. These are the 5 important things which you should know. Normally, renal biopsy is not required. Second, no special investigations of all the other secondary diseases because 85% it is primary. And third thing is, steroids are the treatment. If not responding or relapsing after steroids, non-responders, then you consider calcineurin inhibitors or MMF or other cyclophosphamide or other agents. No prophylactic antibiotics, please. Child is nephrotic syndrome, he may have infection. I would like to cover it. No, don't do that. And no NSAIDs at any cost for this patient. That's also important. No NSAIDs because they worsen the nephrotic syndrome. And then no antithrombotic drugs at all. Okay, these are the 5 or 6 important points that you need to remember in the presentation. It will come somewhere. Okay. Acute in adults.
Yes, the same diuretics, furosemide and spironolactone. In some cases, we use metalozones also, sir. And we have to monitor weight, pulse, and blood pressure regularly. And anticoagulants can be used to prevent thromboembolic complications, but its role is not yet proven. Hypolipidemic agents could be used in patients with secondary
Here
causes.
also one point. No role for routine anticoagulation unless there is evidence of thromboembolic complications. Suppose you have the DVT or pulmonary embolism or renal artery vascular thrombosis, then you can give it. Otherwise, not required. And drugs to reduce cholesterol, triglycerides are not needed. Read the nephrotic syndrome, improve the protein, automatically hyperlipidemia is corrected. You don't require a routine administration of hypolipidemic agents also. That's also important. Okay. Now
Yes.
read the next line.
Secondary nephrotic syndrome will treat the underlying causes, sir. In diabetic nephropathy, widely used to reduce proteinuria are AC inhibitors and ARBs, sir.
You have to give. If it is secondary nephrotic syndrome, particularly diabetic nephropathy with nephrotic syndrome, AC inhibitors and ARB blockers have a role. Even otherwise, in people who have unremitting edema, you can put them on angiotensin converting enzyme inhibitors or ARB blockers in the absence of diabetes also. This has got a evidence B. It's a very important point. Diet, already we have seen 1 gram of protein per kilogram body weight and 3 grams of salt per day. Differential diagnosis.
Yes, sir. The differential diagnosis include hepatic causes like insufficiency, hepatocellular cirrhosis, and Budd-Chiari syndrome. And the digestive causes include exudative enteropathy, lymphangiectasia, malnutrition. And cardiac causes include hereditary angioneurotic edema and anaphylaxis. Renal causes includes chronic
glomerulonephritis. Anaphylaxis, you have also the insect sting also could be a cause of nephrotic syndrome. Sometimes in the tropical countries, when they go in the forest for work, they'll be bitten by insects and bee sting, insect sting. They come with a severe proteinuria on the second or third day, which is insect-related allergic reaction producing nephrotic syndrome. Self-limiting.
Yes, sir.
Insect bite, you remember in our country.
Okay, sir.
Renal.
In renal, chronic glomerulonephritis, diabetic nephropathy, FSGS, and HIV-associated nephropathy, IgA nephropathy, and membranous glomulonephritis, and minimal change disease. Yeah,
there are certain causes which should be differentiated, and this is the list of those causes. Now, staging.
Remission is defined as if urine albumin is nil or trace for 3 consecutive early morning samples, sir.
Correct.
Relapse is initially the patient have been in remission, but now for the next 3 consecutive early morning samples, urine albumin is 3+ or 4+.
Correct.
In frequent relapses, there are 2 or more relapses in the first 6 months or nearly 4 relapses in the 12 months, sir.
That is the case of frequent relapse. 2 relapses in 6 months or 4 relapses in 12 months. Okay. Steroid dependent.
It is defined as 2 relapses when the patient is on alternate day therapy or within 14 days of the discontinuation of steroids.
Yes. Patient discontinued steroids within 2 weeks, the proteinuria comes back. That is what is called steroid dependent.
Yes, sir. Steroid resistance is there is no remission when the patient is on daily prednisolone therapy at a dose of 2 mg per kg per day for 4 weeks.
At least you should have tried 1 mg per kg is the normal dose. You can increase up to 2 mg per kg. 60 kilogram man getting around 120 milligrams per day for 4 weeks. Then also there is no respite. The albuminuria is continuing. It is called steroid resistance.
Yes.
Congenital.
Congenital is they present within the first 3 months of the life, and in these children there is usually a genetic mutation.
As I have told you now, there is an early responder, moderate responder, and then late responder. So early responder 2 weeks, this is 2 weeks, this is 4 weeks, and this is after 6 weeks, non-responder. Like that. Okay? Keep it. This is 0 week. You can put the diagram like that. 0, 2K, and 4, 6 non-responder. Okay. Now, prognosis.
In minimal change disease, treatment with steroids shows excellent prognosis. There are an 85 to 90% are steroid responsive but may relapse. And for patients with FSGS, the prognosis is bad. They generally progress to end-stage renal disease requiring dialysis and kidney transplantations. Only 20% of the patients with FSGS go to remission of proteinuria, and another 10% improve but stay proteinuric.
Correct.
Between 25 to 30% of the patients with FSGS develop ESRD within 5 years.
Yeah.
Yes, sir. Of patients with membranous nephropathy, 30% goes into spontaneous remission. And in patients with persistent nephrotic syndrome, 40 to 50% developed end-stage renal disease within a period of 10 years.
Yeah, now very simple. The prognosis is depending upon the type of the nephrotic syndrome. If it is minimal change disease, majority of them recover. If it is membranous proliferative glomerulonephritis, around 40 to 50% may require lifelong steroids, and at the end of 5 years, they will develop end-stage renal disease. If it is focal glomerulosclerosis, they are steroid resistant, and they will go in for ESRD. It's very early, and transplantation requirement is quite high. These are the 3 things. And if it is secondary nephrotic syndrome, the prognosis depends upon the cause that is causing the nephrotic syndrome. Is it SLE? Is it diabetes? Is it amyloidosis? Is it good posture? Whatever, what is the secondary cause? That plays a role in deciding the prognosis of the patient. Okay. Complications.
The following are the complications: infections, hypocalcemia, non-abnormality, and hyperlipidemia, atherosclerosis, and hypercoagulability. Hypovolemia, acute kidney injury may happen, which suggests underlying glomerulonephritis, but is more commonly precipitated by hypovolemia or sepsis. Additional consequences include hypertension due to reduced kidney function and fluid retention. Edema of the gut could cause defective absorption, leading to malnutrition, ascites, and pleural effusion.
కిషోర్ కాల్ చేసి మార్నింగ్
వాళ్ళ మదర్ అడ్మిట్ అయ్యారంట ఫోకల్ సీజెస్ లో వచ్చాయంట. అరే మాదిరి నెంబర్ ఉందా? నాకు మాదిరి కాంటాక్ట్.
Somebody is speaking. Okay, now go ahead. I'm glad that you have brought in the other tables. Yeah, complications are very straightforward. Metabolic consequences of nephrotic syndrome, infection, hypocalcemia. You should counsel for the bone abnormalities and start supplementing vitamin D and calcium also for these people. Hyperlipidemia can lead to premature atherosclerosis. Hypercoagulability can occur, hypovolemia, and that can lead to have its own problems. Acute kidney injury with underlying glomerulonephritis more commonly respirated by hypovolemia and sepsis, aka due to hypovolemia. Additional consequences include, of course, they may have developed hypertension, fluid retention, edema, and malnutrition because of the edema of the gut. Ascites and pleural effusions can occur. Okay. Now, see the next slide. These tables are from the other article, very nice article.
Yes, sir. Diagnostic criteria for nephrotic syndrome. There's a heavy proteinuria in which 24-hour urine protein is more than 3 to 3.5 gram proteins. And if it's spot urine sample, the PCR ratio should be more than 3 to 3.5 grams.
Correct.
More than 2.
Hypoalbuminemia.
Hypoalbuminemia and serum albumin is less than 2.5 grams per deciliter. And edema, there should be clinical evidence of peripheral edema, and hyperlipidemia is not usually required for diagnosis. Severe hyperlipidemia, especially total cholesterol and triglycerides. Total cholesterol more than 350.
You must demonstrate heavy proteinuria, hypoalbuminemia, and edema. cholesterol may be elevated, not a diagnostic criterion. All these in the absence of cardiac or hepatic cause. You should have excluded the cardiac or hepatic cause, underlying cause for the edema. Okay.
Yes.
Yeah,
Yes.
this is also very interesting chapter.
In diagnosis of nephrotic syndrome, first we'll confirm whether it's nephrotic syndrome or not, based on urine analysis, sir. In CE, albuminuria more than 3+ or 4+, and early morning urinary protein more than 3 to 3.5 grams milligrams per 3 to 3.5 mg protein per 300 to 350 mg of creatinine UPCR ratio, sir.
Yeah.
And serum albumin less than 2.5, sir.
Okay.
And we'll look for the etiology. In urine analysis, we'll see whether hematuria or CAS, which we can rule out, so that we can rule out nephritis.
Correct.
Blood counts and coagulation panel, if there is to rule out any bleeding disorder. And renal function and electrolytes. An elevated creatinine level may indicate acute kidney injury and indicates reduced GFR. And liver functional test, if elevated transaminase levels, may suggest viral hepatitis. And glucose test for diabetes mellitus, which causes secondary nephrotic syndrome.
Yeah, among these, the coagulation panel is optional. May not have to do for everyone. Wherever there is an indication for coagulation disorder, you can do the coagulation panel. RFT, LFT, glucose urine analysis can be done routinely. Apart from the demonstrating proteinuria, severe proteinuria in the urine by spot protein, urine protein, and or the 24-hour urine protein creatinine ratio. Okay, next.
For underlying causes, based on history and physical examination, we'll go for further investigations. For autoimmune things, anti-nuclear antibody, anti-double-stranded DNA, and complement levels for SLE, sir.
Yeah, again, as I told you, these are not routinely required unless you are suspecting a secondary cause as the nephrotic syndrome. In primary nephrotic syndrome, we don't require to evaluate all these things. Okay.
Okay, sir.
This is for the assessing the underlying condition. That is for the secondary disorder. Step 3. Okay.
And any pleural effusions, we can detect it on chest X-ray. And echocardiography, if to rule out any heart failure is there or not, and abdominal ultrasound sonography for ascites, if ascites is suspected. Renal ultrasound for if GFR is reduced, and viral hepatitis panel if transaminase levels are abnormal.
Only in selected cases. Okay. Now, assess for disease complications.
For disease complications, based on history and physical examination, same renal ultrasonography and lower extremity Doppler ultrasonography, chest CT, or lung ventilation perfusion scan if any pulmonary thromboembolism is suspected, sir.
Okay. Only in those cases where you are suspecting complications, you do those things. And renal biopsy is the final step.
Yes, sir. For biopsy, nephrologist consultation should be taken and should be considered if it will inform management or any severe disease or lack of response to the treatment or steroid resistant cases. We will go for renal biopsy, sir.
So for me to consider renal biopsy, is it going to contribute for my treatment? Is it severe disease, something like a focal glomerular sclerosis, I'm considering. 3, is there any secondary causes I'm considering? 4, is there any lack of response or non-responders to steroid or steroid resistance? Then you can consider biopsy, not as a routine. So renal biopsy and doing all the other tests related to autoimmune conditions are reserved only for select cases, not for everyone. DVT, though it is a complication, it is not such a common thing to occur in nephrotic syndrome. Yeah, when I read an article, as I told you, I always underline the important points. We have covered most of them. This table also I would have liked to be shown. What are the secondary causes of nephrotic syndrome? Go to the table and say, circulate the articles to all the PGs. Metabolic causes, amyloidosis, diabetes, immunological causes, idiopathic and primary, medication, heroin, interferon alpha. Yeah, this information is there in your presentation. You have brought them. This table like this would have given some better understanding. Okay. Now,
Okay, sir.
diagnostic criteria slide you have presented. This assessment also you have presented very nicely. This also differential diagnosis also you have presented the slide. Yeah, this is what important. Key important practice guidelines. Okay. Spot urine protein creatinine ratio should be used for 24-hour protein collection to confirm the nephrotic range of proteinuria. Okay, that is number one. Number two, although venous thrombosis is a common complication, there is no evidence that anticoagulation is indicated in all patients of NS. That is number two learning point. Although hyperlipidemia is common complication of NS, there is no evidence that lipid-lowering therapy should be initiated solely to treat the manifestations of nephrotic. Suppose you have got some cardiac disease or some other condition which requires statins for the dyslipidemia, that is different. Just to treat nephrotic syndrome dyslipidemia, you don't require it. Therapy with sodium restriction, fluid restriction, loop diuretic, ACE inhibitors and angiotensin receptor blockers is a conservative management approach appropriate for most patients of nephrotic syndrome. Okay, all are the hyperlipidemia, no treatment separately is A grade. Other three which we have read, C grade, and B grade is corticosteroids and other immunosuppressants may have some benefit in patients with NS, but the potential risks are significant and there is no evidence or guidelines recommending the use of this drug in all patients for a long period. So you have to see, for example, focal glomerular sclerosis. Corticosteroids are not going to do anything because they are not responsive. Okay, there is a secondary cause. Unless you are diabetic, you can't give just corticosteroids. So treat depending on the patient, steroid is required or not, is to be considered. Children, certainly yes, because 85% is minimal change disease and they are steroid responders. Okay, so this is the table I wanted you to look at. So this one also I wanted you to see this table. What are the potential immunosuppressive agents I can give? ACTH, alkylating agents like chlorambucil, leuceron, or cyclophosphamide, azathioprine, immuron, biologicals like rituximab or eculizumab, calcineurin inhibitors like cyclosporin or tacrolimus, high-dose immunoglobulins, and then mycophenolate mofetil, Cellcept it is called. Or sometimes you can use, Thunder God in traditional Chinese immunosuppressive therapy also. These are the various immunosuppressive therapies available. Most important being corticosteroid, not responsive, calcineurin inhibitor, or MMF, or cyclophosphamide. Remember, you have to consult the nephrologist to take a decision on 1, anticoagulant, 2, on the type of immunosuppression, and 3, on the need for renal biopsy. You have to consult the nephrologist. Okay. So I think both the articles are very good. I request you to share these articles with all the PGs and
Yes,
also the faculty also you share, faculty members also for the faculty group. Let them read both the articles and you, whatever assignments I have told you, all of you please write and show me. So it is around 1.5 hours. We will now stop here unless you have any questions.
Sarma, sir.